I invite Dr. J.C. Mohan. He'll be talking on hypertension in elderly. Professor J.C. Mohan, please.
Thank you, Dr. Khanna, for inviting me to this important symposium on hypertension. And my mandate is to talk about hypertension in the elderly. Blood pressure is a biomarker of cardiovascular health, and it has a definite normal range in children, adults, and elderly people, and definite threshold of abnormalcy. The blood pressure, which is a mechanical oscillating wave traveling through the vascular system, arterial system, actually has a peak called systolic blood pressure, which increases throughout life as the age advances. It has a nadir called diastolic blood pressure, which increases till the age of middle age, and then it starts falling. And we, of course, have pulse pressure, which continues to rise throughout life. And of course, mean arterial pressure, which actually does rise throughout the age, but at a much lesser speed. Whichever way you denote hypertension, as Dr. Khanna was saying, whether 140 by 90 or 130 by 80, the new ACCHA 2017 guidelines, there is no doubt that hypertension is genetically predetermined, age-dependent, environmentally influenced, nearly universal vascular disease. Why it is universal vascular disease? Because the lifetime risk of developing hypertension in human race is more than 90%. And WHO has defined hypertension as a humanitarian tragedy at a planetary scale. And one of the reasons is that the elderly population in the world is increasing, and at least 70% of the elderly population has hypertension. Hypertension is associated with ischemic heart disease, ischemic stroke, intracerebral hemorrhage, kidney disease, and heart failure. And it has a linear relationship throughout the entire spectrum of degree or scale of hypertension. But since we are talking about hypertension in the elderly, we need to keep in mind that age and hypertension are the most powerful cardiovascular risk factors. Below the age, compared to below the age of 70 years, above the age of 70 years, the cardiovascular death is nearly 3 times more common. Stroke is nearly 2.5 times more common. The important thing is that when we look at the hazard of cardiovascular events and correlate it with blood pressure and age, as shown here, you would realize that there is a big gap as far as beginning of the blood pressure is concerned, or initial stage of blood pressure is concerned, between young people and old people. The lower line suggests shows people at the age of 40 to 49 years, and the upper black line 70 to 79 years. The hazard ratio for same level of blood pressure shown on x-axis is much greater when the blood pressure is in range which you could call mild stage 1 or stage 2. However, that difference tends to taper off once you reach a stage what one would call as stage 3 or more. So one needs to understand that the hypertension needs to be controlled in elderly population more aggressively, because even a small rise in blood pressure denotes a much higher risk. So how is the hypertension in India? This is a prevalence of hypertension study from rural Kerala, showing that above the age of 70 years, 65% of all individuals have hypertension. Rajiv Gupta actually in Jaipur Heart Watch study 4 showed that prevalence is related to age, and those who cross the age of 70 or more, 85% of the urban population has hypertension, and that is a staggering number when you realize 85% of the entire elderly population above the age of 70 years has hypertension. We also have to understand that the sole defining feature of hypertension in the elderly is systolic blood pressure. And so you would just have to focus on systolic blood pressure in elderly. If you control systolic blood pressure, diastolic blood is 100% controlled. However, lower diastolic blood pressure may be an issue, especially if it is less than 60 millimeter of mercury. So the characteristics of the Rhiatic hypertension are decreased vascular compliance, and this decreased vascular compliance means that you need actually more drugs which will improve the arterial compliance, like calcium channel blockers, and that is why these are more effective. Decreased baroreceptor sensitivity, showing decreased efficacy of sympatholytic drugs, especially beta blockers. Increased salt sensitivity of blood pressure with increasing age, showing the greater utility of thiazide like diuretics. Increased total and central adiposity, and neurohumoral changes in aging. But if you see the reduction in blood pressure and the benefit with regard to cardiovascular events, that is similar whether the individuals are younger and older. When we talk of relative risk, obviously absolute risk has to be much higher in elderly individuals. But if you talk in relative percentage terms, benefit is almost of the same grade. So what should be the target of blood pressure actually in elderly individuals? We have come down now to the ACC-HA criteria of 130 and below for systolic blood pressure. And as I said, in elderly, we wouldn't talk about diastolic pressure as much. We will be focusing on systolic blood pressure. We know that JNC7 said 140 should be the target, what we should try to achieve. And throughout the SHEP, HIVET, and SPRINT trial, we have moved down, although JNC8 temporarily in 2013 did suggest that 150 may be acceptable in elderly individuals. Nevertheless, there is powerful data to suggest that we need to lower blood pressure in elderly individuals. And this is, of course, the SPRINT data. Mean age of these individuals was 68 years, and they were all people without diabetes. A large number of people. A 1 millimeter reduction in systolic blood pressure resulted in all-cause mortality reduction 2% and cardiovascular mortality reduction of 3%. However, if you look at the elderly individuals and so-called SPRINT elderly study, 1/3 of all people were elderly. Mean age was 80 years with additional risk factor. And here, a 1 millimeter reduction in systolic blood pressure reduced the all-cause mortality by 3%. And cardiovascular mortality was nearly 4%. That is an impressive number. That suggests that if you want to improve the longevity of elderly people, blood pressure reduction is absolutely must. The interesting data also suggests that every 1 millimeter fall in systolic blood pressure in elderly leads to 3% relative risk reduction of stroke and 3 to 5% relative risk reduction of heart failure. So let us have a quick review of hypertension trials in the elderly. We start with the SHEP trial, systolic hypertension in the elderly. These were individuals who had a mean age of 72 years, 4.5 years of follow-up, nearly 4,700 patients, placebo compared with chlorthalidone, and we had a 36% reduction in stroke. So the primary endpoint was stroke, and there was a 36% reduction. What is impressive is that the number needed to treat was 33. Infarction were reduced by 27%, all-cause death by 13%, all major cardiovascular events by 55%, showing that the number needed to treat is 18. That tells us very, very persuasive data to lower blood pressure in the elderly. So what was the difference? Difference was 12 millimeters. Still, the achievement on therapy, the blood pressure was still 143 by 68. Clearly, by present criteria, that achieved blood pressure would be unacceptable. The SYST-UR was the second study. This was study of isolated systolic hypertension above the age of 60 years. Again, there was a 10 millimeter difference between placebo and therapy. Remember, these were elderly people. And of course, the drug used was nitendipine plus minus enalapril. And again, in 2 years follow-up, you had the 42% reduction in stroke and cardiovascular mortality reduction 27%, and cardiovascular events of 33%, clearly indicating that blood pressure reduction is very, very desirable in elderly individuals. The interesting data of CIS-YOR, total mortality in individuals above the age of 60 years, the data suggests that combination therapy, although it produces just a 3 millimeter difference in systolic blood pressure, reduces actually total mortality by 32%. You need to understand by synergistic mechanisms, both ACE inhibitors and calcium channel blocker try to provide much incremental benefit than you see with a drug alone. The same is available with death, MI, stroke, and heart failure, the 4-point endpoint, although the combined had a 9.5 millimeter reduction in with the combination therapy systolic blood pressure, you see a 50% reduction in primary endpoint. Somehow there is a synergy between calcium channel blockers and anti-RAS agents in the elderly individuals. We come back to the SPRINT study, SPRINT elderly sub-study, not the SPRINT study as such. That is age above the age above 75 years. And these are individuals who are non-diabetic and 2,600 odd patients. What we found that intensive therapy with an 11 millimeter difference in blood pressure and finally achieved systolic blood pressure 123 resulted in 34% cumulative hazard reduction of cardiovascular death, non-fatal MI, non-fatal myocardial stroke, and of course rehospitalization for unstable angina and resuscitated cardiac arrest and heart failure. Not only that, the elderly study did show that intensive therapy bringing it down to 123, final aim was to bring it down below 120, resulted in MI reduction 28%, stroke 29%, heart failure 38%. The SPRINT elderly study, when you look at all-cause mortality, and by achieving 11 millimeter fall in blood pressure from a level of 134 to 123, from standard to intensive therapy, resulted in 33% reduction of all-cause mortality. So obviously, of course, we know the way in SPRINT study, the blood pressure was measured by oscillometry method, and you could probably add 10 millimeter to this office blood pressure. And nevertheless, this suggests that you should try to achieve an office blood pressure of close to 130, and that would result in a all-cause mortality reduction of 67%. People have doubts whether frail elderly people should have that intensive blood pressure reduction, and the SPRINT trial in the moderately frail elderly people showed again a 32% reduction in cumulative hazard when these people were treated with intensive therapy versus standard therapy. As far as adverse effects were concerned, there were little more hypotension, little more syncope, little more acute kidney injury, but not too much difference. But we need to keep in mind that there is a small price to pay when you intensively treat hypertensive individuals. But there is data to contrary as well from SPRINT trial. The accomplished trial showed that if the age of entry is less than 70 years, then there is a persistent benefit as you move from a target of below 140 to 130 millimeter mercury in younger individuals. But age above 70 years, as you move below 140 to below 130, that benefit is lost. But these are, of course, 2/3 of these people were diabetic. Keep in mind, SPRINT study did not have diabetic individuals. HIVAT was another study of very elderly individuals with indapamide, and it showed actually a 15 millimeter reduction in systolic pressure. There was a significant reduction in stroke, heart failure, cardiovascular death, all-cause mortality. Another issue has been which drug to initiate. Of course, the NICE guidelines are well known. We said C or D, whether calcium channel blocker diuretics should be preferred. And that is based on renal profiling of hypertensive individuals. It is believed that elderly people have V-type hypertension, volume expanded, salt sensitive, and these volume expanded salt sensitive individuals respond much better to calcium channel blockers and diuretics. That was the premise on which SHEP study was done and HIVAT was done. Obviously, the SPRINT study actually used anti-RAS agents in most of the patients, and the benefit were very, very similar. This CLIC trial has already been talked by Dr. Khanna. We wouldn't go, but the important thing is that these individuals, 160 individuals, they had a mean age of 66 years, and you could say that this is also a trial of chlorthalidone in elderly hypertensive with advanced chronic kidney disease, and there was a significant reduction in blood pressure, significant reduction in urinary albumin creatinine ratio, and all one can easily say that elderly people actually with advanced kidney disease, they should not be denied the benefit of chlorthalidone. But we have to say data may not apply to frail, multi-morbid and old patients on polypharmacy, and we need to keep that in mind. And treatment shouldn't be so intense as to reduce diastolic pressure below 60 millimeter mercury in older people because age shifts the lower autoregulatory control upwards. Individuals most likely to be harmed with intensive control, where you try to bring the target below 130, or who have no cardiovascular disease, age above 80 years, moderate to severe frailty, cognitive impairment, a labile blood pressure, life expectancy less than 12 years. Individuals most likely to benefit with intensity are those who are of any age, who are fit and have high baseline systolic blood pressure, high cardiovascular risk, previous stroke, and stage 3 and 4 kidney disease. So let me summarize. Treating hypertension in the elderly is well justified. Appropriate to recommend an office measure systolic blood pressure target of around 130 millimeter in older people. Any of the major antihypertensive drug classes can be used, although some of the guidelines still say that you should use CCBA diuretics as the first choice. Treatment is well tolerated. Be cautious about orthostatic hypersymptoms, and of course, monitor renal function more often. Thank you very much.
Thank you, Dr. Mohan. That was indeed wonderful, as lucid and as clear as you are always.